Pathology of brain tumors. So there is abnormal CNS cell growth or metastasis to the CNS. It causes inflammation, compression, and infiltration of the tissue. Increased intracranial pressure and cerebral edema, seizure activity and focal neurological signs, hydrocephalus, and altered pituitary function. The etiology of brain tumors. We all know that the incidence is high in well-developed countries, but this may be due to improved imaging that we have here, like the United States, where they don't have in other countries, so we might just know about it before other people do, and we also have the ability to take actions. Certain genetic conditions, such as neurofibromatosis, are associated with brain tumors. Ionizing radiation exposure is the only known modifiable risk factor, and metastatic brain tumors are twice as common as primary brain tumors. Our assessment will find headache, nausea and vomiting, visual disturbances, seizures, changes in level of consciousness, and papillary edema. The tests that are run on patients with brain tumors are MRIs, CT scans, and PET scans. Non-surgical treatments include radiation. This is often done before surgery to shrink the tumor to decrease the tissue damage caused by the surgery. Also, chemotherapy helps to shrink the tumors or to stop or slow cell growth. Surgical treatments include craniotomy with microscope and microsurgical instrumentation, and this has come a long way in the last 10 years. Often they can do partial removal or decompression, and then they can do complete removals. So partial removal will be done if the tumor is infringing on parts that are going to cause more damage. And complete removals obviously are optimal, but aren't always possible. And for pituitary tumors, the transsphenoidal microsurgical removal is done, and there's some good pictures in your book of that. Medications to know. First one's dexamethasone or Decadron. It is a corticosteroid, and it controls cerebral edema. And there's phenytoin and phenobarbital. They're both anticonvulsants, and they're used to treat and control seizures. There is temolizumab. It's the first oral chemotherapy that crosses the blood-brain barrier, and it's used in treating malignant gliomas. Osmotic diuretics. This would include mannitol or hypertonic saline. It decreases the fluid content of the brain, which helps to decrease the intracranial pressure that may be caused by excess fluid in the brain. Inadequate tissue perfusion. All of these are post-op complications of a craniotomy, so that's something you need to know. You could have inadequate tissue perfusion. We need to monitor vital signs, make sure to maintain adequate oxygen saturations. Hypoxia equals decreased cerebral perfusion. They may have increased intracranial pressure, so we're going to do positioning, which would be putting that head into that neutral position and avoid hip flexion. We're going to prevent vagal reflex. We're going to decrease the stimulation in the room. We're going to monitor vital signs and neurological status, and they may also get mannitol and osmotic diuretic. Bleeding and hypovolemic shock, so we're going to monitor H&H, signs of bleeding, and CNS leaks. We're going to watch their fluid and electrolyte disturbances. We're going to monitor electrolytes, their input and output, and we're going to monitor for signs of diabetes insipidus and syndrome of inappropriate antidiuretic hormone. Infection, we're going to monitor our incision, wash our hands, use antibiotics to prevent meningitis, which is a major complication of post-craniotomy. We're also going to watch for those CSF leaks, so look for wet bandages, clear drainage from the nose or ear. And then seizures, which are a major complication, we're going to try to prevent those with anticonvulsants. A little bit about diabetes insipidus and the syndrome of inappropriate antidiuretic hormone secretion. They're caused by complications of increased intracranial pressure. So just remember, DI is deficiency of antidiuretic hormone, and SIADH is surplus of antidiuretic hormone. Remember that double negative going on. It's an antidiuretic. So that's where the trickiness comes in. So with diabetes insipidus, you have a fluid volume deficit, and you have decreased antidiuretic hormone. You have sodium that's increased because the patient is hemoconcentrated. And then you have urine output is increased, and it's clear and dilute, and it looks just like water. And then SIADH, you have fluid volume excess. You have increased ADH, or antidiuretic hormone. Your sodium is decreased because of hemodilution, and the urine output is decreased and concentrated. Spinal cord injuries. So most of them result from bruising of the spinal cord or loss of blood flow to the cord, not cutting of the cord. So you have complete injuries or incomplete. So that means across the section of the cord, it's going to be all damaged all the way across, or sometimes it's just part of the cord that's damaged, not the complete transection. Then there's primary injury. This is when the injury first occurs. And then there's secondary injury, and this is related to swelling and reduced blood flow or bone fragment. There are 5 mechanisms of injury. There's hyperflexion. The head is accelerated forward. On a head-on NVA, the vertebrae are compressing the cord. Then there's hyperextension. This happens with rear-ended NVAs. The chin is struck and the spinal cord is distorted. Then there's vertebral compression. This happens with diving, falling on the buttocks or feet. Bone fragments pierce the cord. Then there's rotation. The head is turned past normal range of motion, tearing the spinal column ligaments. And then there are penetrating injuries like a knife or a gunshot, and this causes a transection of the cord. It cuts it in half. NVAs are the biggest cause of spinal cord injuries at 44%. Active violence is 24%. Falls are 22%. Sports are 8%, and 2/3 of those are diving accidents. Others are 2%. So on our assessment, we're going to make sure we maintain the airway. They're probably going to be intubated. We're going to keep that neck in a neutral position. Breathing. So ventilators are required for C3 and above injuries. Circulation, they're going to need an EKG, and disability, we're going to score those motor movements on a 0 to 5 scale. So these are just little squares to memorize. C1, they're going to have tetraplegia or quadriplegia, and they're going to be ventilator dependent. C5 through 8, they're going to be tetraplegic. Their head control will be progressive from elbow to finger, and the lower the injury, the more control they have of the hand. And then T11 to L5, they're paraplegic. Some may have ankle use, but they're all going to have more independent ambulation because they have upper body strength. The ASIA scale is used to assess spinal cord injuries. It is an A to E scale for each body part, A being complete loss of sensation and motor control, and E is normal sensory and motor function. And tetraplegia and tetraplesis means weakness or paralysis of all extremities, and paraplegia and paraparesis is paralysis and weakness of lower two extremities. And this is just a picture of a spinal cord injury, an x-ray. So plan of care, we're first going to do those ABCs, maintain our airway, their breathing, their circulation. We're also going to put in place immobilization to prevent further injury to the cord. This can be a backboard and cervical collar. If you're at the scene of an injury, that means log rolling, not using chin tilt during CPR. We're going to use jaw thrust, but being very careful not to further injure the cord. So that they may need casts or braces for back injuries, and then we're going to learn about the ones for cervical injuries. Surgical interventions may be decompression, that's removing the bone that's pressing into the spinal cord, or stabilization to realign the spine and the area of the spinal cord injury. So a halo device provides immobilization of the cervical spine while allowing the patient to ambulate. Early ambulation helps us to keep away like embolisms and pneumonias and constipation, so that usually has the best outcome. And just because they have a cervical spine injury doesn't mean they're going to be paralyzed. They have to have a complete injury of the cord to have complete paralysis. So it looks like this patient has some movement. But basically the halo is actually pinned into the skull, and then the weight is distributed over the rest of the vest, and that keeps the C-spine in place. Crutchfield tongs are used as a skeletal traction, so that's kind of pulling it out and keeping it stable until the time of surgery. The patient cannot get up with cervical tongs, cervical or skeletal tongs, excuse me. The other name is Crutchfield tongs. Complications for spinal cord injuries could be neurogenic shock, and this one is rare. They will have injury to the sympathetic pathways of the spinal cord. They decrease sympathetic tone. It'll decrease the baroreceptor response and it will cause vasodilation and decrease thermoregulation. The patient will display bradycardia, hypovolemia, and decreased temperature. For bradycardia, we're going to give them IV atropine. For the hypovolemia, we give them intravenous fluids. And then for the decreased temperature, we treat that with a warming blanket. Now, if these are not treated, there will be venous pooling, decreased cardiac output, inadequate tissue perfusion, and then anaerobic metabolism. The next one is called autonomic hyperreflexia or dysreflexia. It is shown by, it's caused by an overactivity of the autonomic nervous system. It is an emergency situation. Not treating it will lead to seizures, stroke, and even death, so it is an emergency. And what causes it's anything that's painful, uncomfortable, or physically irritating. Overfilled bladder is the most common cause. A bowel full of stool or gas is the second cause. So what we're going to do is, if we notice increased blood pressure, pounding headache, bradycardia, or stuffy nose, we're going to automatically sit that patient up. We're going to check their bladder, and then we're going to check their rectum. And then if we can't figure it out, we're going to call 911 if we're not in an acute care setting. But if we are, then we may call a rapid response. The patient that I had, all those things were good, but it was an ingrown toenail. And so we couldn't figure out what was going on, and so we called a rapid. Mechanical force causes a tissue injury to the brain. So we're going to talk about traumatic brain injuries. The traumatic brain injury will cause decreased oxygen and glucose to the brain tissue. There's two types, open and closed. Open includes skull fracture or penetrating injury, and closed includes concussion, contusion, and laceration. And the picture over on the side here is actually an open because it is a skull fracture. So injuries to different parts of the brains will obviously cause different deficits or problems. And on this slide, it shows where those different lobes are and what are the different deficits that they may experience when they have brain damage in that site. This slide is a picture of different ICP monitoring devices. What you need to know is that ICP monitoring devices can regulate intracranial pressure as well as measure it. Increased ICP is what's going to cause major problems for our brain injuries or our patients who are post-op brain surgery. Normal ICP is 0 to 10. Increased ICP can be caused by edema, hematoma, inflammation, brain tumors, anything that's taking up space that the brain needs to be. Management of increased intracranial pressure. So remember, we have to think about the ABCs first, but then we can talk more about positioning. We need to do that neutral head position, avoid hip flexion, reduce noxious stimuli. They may have to insert a monitoring device, and that monitoring device can assess and treat intracranial pressure. It can act as a drain. But complications associated with that are catheter obstruction, infection, and hemorrhage. Mannitol, again, can be used for intracranial pressure that's high. It is an osmotic diuretic. We know it's working because they are urinating. Barbiturate comas, they can decrease the metabolic demands of the brain. And that's very helpful with head injuries. So a patient is put on IV pentobarbital or thiopental. The problem with having a patient in a barbiturate coma, it makes it very hard to assess neurological changes. Patients with brain injuries can often get decompressive craniotomies. So that's removing ischemic or non-vital brain tissue. Also, it can remove hematomas. This allows room for expansion of healthy tissue and reduces the intracranial pressure. We also need to assess for diabetes insipidus or SIADH because of that increase in intracranial pressure. A patient is also at risk for herniation, and basically that's where the brain is slipping into the space of the spinal cord. So Cushing's reflex, the patient will have severe hypertension and bradycardia and widening pulse pressures, and uncal herniation is dilated pupils, patient becomes flaccid, and they have respiratory arrest.